This is Professor Michael Chapman. I'm one of the most experienced IVF doctors in Australia. I believe that an important part that I can contribute is to educate patients in relation to fertility, infertility, and all that involves. These series of podcasts help to educate you. I hope they are helpful to you. If you wish to know more, however, I'm more than happy to have you contact me via email, which is profmchapman@gmail.com, or make an appointment to see me on 9138 4222. Today, that's very unusual to be in that situation, because what we do is to give a trigger injection that is different to the standard HCG injection, and what that results in is almost no ovarian hyperstimulation. However, it does have an impact on the ovary in the sense that it actually switches off hormone production, and the lining of the womb breaks down much more quickly. So if you are in a situation of potentially having the OHSS syndrome, the doctors these days would probably give you something called a decapeptyl trigger, and then you would get a period after the egg collection, a period something like 6 or 7 days later, quite quickly. And those embryos that would have been created have been frozen ready for that next cycle. So that's the second reason where there's potential for OHSS, and we've used a decapeptyl trigger. The third reason for freeze-all is some women, certainly more commonly in women over 40, their progesterone levels, which should be low around the day of the trigger, have already started to rise. And so the lining of the womb is prematurely being matured ahead of time, so that when the embryo gets to day 5 and ready for transfer, the lining of the womb actually thinks it's day 10 or so. And what that means is that the endometrium doesn't think that there's going to be a pregnancy, and it's true. Pregnancies are about half the normal progesterone when there are normal progesterone levels. So when we see an elevated progesterone on the day of trigger, we may well decide to freeze all the embryos because of that reduced chance of success. And then, as I said earlier, the other reason is that some clinics just do it as a routine for convenience of the patient and the doctor. The embryos, once they're frozen, basically can stay frozen forever. They're in a state of limbo. There are pregnancies reported of an embryo that's been frozen for over 20 years where a pregnancy has occurred. It's a long-lasting process. The normal situation for most women is that they go through a cycle. They're lucky they end up with more than one embryo. The best embryo is put back fresh, and the rest are frozen for future use. So that future use may be the next cycle, because the fresh one didn't work, or it may be in 2 years' time or so, be the next baby. So out of one cycle, because of the high level of success with frozen embryos, the technology has allowed us to obtain embryos that will be good for a long time, and out of one cycle you can get more than one baby. My best effort is 3 babies from one IVF cycle, 1 fresh and 2 frozen subsequent transfers. Freezing embryos today is a routine. It is safe. Frozen embryos have no different outcomes than fresh. There is a slight suggestion, in fact, that frozen transfers might result in slightly bigger babies. Not abnormally big babies, but bigger than the IVF babies that in average terms are slightly less big than a spontaneously conceived baby. But it's a marginal difference. Don't be upset if you end up having a freeze-all cycle for whatever reason. Your chances of success have not been impaired by that possibility.
And don't forget that you can access all the previous episodes by going to our website www.theivfjourney.com and select IVF Journey podcast from the navigation menu.